Hello friends, I hope you all are doing great. In today's video, I am going to discuss about the platelet series, which is the thrombocyte. Thrombo means clot. They help in clot formation. They are manufactured in bone marrow by the megakaryocyte. They are the fragments of the cytoplasm of megakaryocyte. One megakaryocyte produces about 4,000 of platelet. Then the normal platelet size is about 1 to 3 micrometer, blue-gray in color, contain fine purple pink granule. They are present in ratio to red cell is about 10 raised to 40 to 1. Approximately 7 to 20 platelet are present in oil immersion or 100x filled. So how to count the approx platelet count is the platelet seen in per 100 x or oil immersion field multiplied by 20,000. So if we multiply the 7 to 27 or approx 10 platelets are seen, we multiply 10 to 20,000, it will comes nearly around 2 lakh, which is the normal platelet count. The lifespan of platelet is about 9 to 12 days. And the production is regulated by the thrombopoietin, which is produced in liver. So liver is helpful in production, and it is removed by the spleen. The older damaged platelet are removed there. Now, the common causes for the decrease and increase of platelet. As I have discussed the decrease in platelet, the mechanism of decreased platelet in previous video, but in this video I will discussing the common causes. The most common presenting cases of thrombocytopenia in our hospitals are the viral, which is seen in HIV and dengue. Then the malarial parasite infection, systemic lupus erythematosus, acute leukemia, DIC in gynec patient commonly. Then the medication of like immunosuppression or myelosuppressor therapy. Then the hypersplenism, which increases the destruction, and the B12 deficiency, which is the one of the most common case of pancytopenia in our developing countries like India. Now the causes of increased platelet, which is further divided into 3 categories. It might be due to the myeloproliferative disorder, extravascular pool, or secondary to other condition. In myeloproliferative disorder, there is essential thrombocythemia, polycythemia vera, myelofibrosis, and chronic granulocytic leukemia. While extravascular pool, there is the splenectomy, exercise, or pertussion. And the second, it might be platelet increased secondary to the iron deficiency anemia, some malignancy, infection, blood loss, which is seen in post-surgery, or recovery from the thrombocytopenia. Now, I am going to discuss some parameters related to platelets. First is the MPV, which is also known as mean platelet volume. It is the same equivalent to the MCV of the RBC. The normal MPV is about 7.4 to 10.4 femtoliter. More the young the platelet, large is the size, and the more is the MPV. So MPV is indirectly proportional to platelet number. So in cases of ITP, we are seeing the high MPV as the platelet count is decreasing. Then now the terminology, large and giant platelet. Platelet is called large when its size is around 4 to 8 micrometer. As I have discussed in first slide, that's the normal size of platelet is 1 to 3 micrometer. So if the size is 4 to 8, then it's called a large platelet, and the giant platelet is the equal or larger than the erythrocyte. The normal erythrocyte size is around 7 to 9 micrometer. So equal or more is known as giant platelet. So MPV is the early indicator of bone marrow problem, which helps physician to detect the marrow problem of decreased platelet before it actually appears. Now, the causes of increased mean platelet volume and decreased mean platelet volume. It is increased in ITP, Bernard-Soulier disease, May-Hagelin anomaly, sepsis, then the CML, DIC, TTP, and many others. And the decrease in mainly aplastic anemia, viscotalsis syndrome, storage pool disorder, and megaloblastic anemia are the common causes. Now, another parameter is PDW, which is also known as platelet distribution width. The normal platelet distribution width is 9 to 13 femtoliter. It increased in case of essential thrombocythemia, while it's remain normal in reactive thrombocytosis. So it is the differentiating point between these two. Now, next parameter is PCT, which is also known as platelet crit. The normal platelet crit is 0.110 to 0.280. It is related to number of platelet and the mean platelet volume. Now, next one is the immature platelet fraction, which is given in the percentage. It helps to assess the thrombopoiesis in case of autoimmune thrombocytopenic purpura and the thrombotic thrombocytopenic purpura. It is the very sensitive parameter and accurate to give the immature percentage of platelet. Now, here is the summary to what to look when you find the thrombocytopenia on CBC. We have to look in all the three series. In RBC lineage, if there is thrombocytopenia along with schistocyte or fragment RBC, we can think of hemolytic anemia, DIC, HUS. If malaria parasite seen on PS, then the thrombocytopenia might be due to falci infection. If the spherocyte seen, it might be due to autoimmune hemolytic anemia. Then if the normoblast and polychromasia are seen, then it might be due to HELP syndrome. And if the autoagglutination seen on PS, it can be due to the cold antibodies. Now, in WBC lineage, if the thrombocytopenia is there and the increased polymorph, it might be seen in infection or the sepsis. If the toxic granulation seen, that might be due to septicemia, precursor cells, blast, leukemia, dysplastic cells present, then it might be due to the MDS. Now, in platelet lineage, the giant platelet are seen in ITP, Bernard-Solius, Meheglin, and the other syndromes, while the scatter platelet in direct smear is due to Glanzmann's thrombocythemia. While examining the smear, the thrombocytopenic patient makes sure to examine the edges of the smear. This means the platelet clump migrate here. The platelet clump might give us the pseudo thrombocytopenia, which might be due to the EIPA, which I have already discussed in my previous video.